The New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS, and its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly, and good evening, everyone, and welcome to tonight's webinar. Before I introduce tonight's presenter, I'd like to remind you again about a couple of upcoming deadlines. NJCTS offers scholarships to graduating high school seniors who are going on to either 2- or 4-year programs. Scholarship applications are available on our website and must be received in the office by April 21st. Also, there must be some of you listening who have experienced a teacher who has really made a difference for your child. And when you come across a professional like that, it's really wonderful. So if you know of a teacher in New Jersey who has made a difference for your child, then download the application on our website and acknowledge that teacher, and you will absolutely make her day. The deadline for those applications is also April 21st. Now to the introduction of tonight's presenter, Dr. Roger Kurlan. Dr. Kurlan obtained his bachelor's degree from the University of Rochester and his medical degree from the Washington University School of Medicine in St. Louis. He did his residency in neurology and a fellowship in movement disorders and clinical neuropharmacology at the University of Rochester Medical Center, where he was on the faculty from 1984 to 2009. Dr. Kurlan is recognized internationally for his clinical and research expertise in neurological movement disorders. He is a founding member of the Parkinson Study Group and the founder and current leader of the Tourette Syndrome Study Group, which is a collaboration of international research groups that conduct large-scale investigations. Dr. Kurlan currently is at the Center for Neurological and Neurodevelopmental Health in Voorhees and Rutherford, New Jersey, where he continues his clinical care and research. This is Dr. Kurlan's third appearance in our Wednesday webinar series, and we are delighted to have him back. Dr. Kurlan, welcome, and I'm delighted now to turn tonight's presentation over to you.
Thank you, Marty. It's a pleasure to speak to everyone tonight. Tonight I will be focusing on the treatment of Tourette syndrome, and I know this is a topic that can be quite technical for some people in the audience, but I'll try to soften things a bit. Also, I'll be discussing general aspects of treatment for Tourette's, but keep in mind that each patient is different and there may be individual differences related to treatment. Generally, the beginning of therapy for Tourette syndrome involves what I call non-pharmacologic or non-medication treatment.
Dr. Kurlan?
The very first thing would be to educate the patient and their family about Tourette syndrome, and also to provide reassurance that it's a treatable condition, and also that it tends to have quite a good prognosis.
Dr.
With
Kurlan?
many patients.
Excuse me, Dr. Kurlan, I apologize. We're not seeing your slides. Did you click show my screen?
Let me do that. How's that?
Great, thank you.
Okay, sorry.
It's okay.
So as I was saying, we generally start with non-pharmacological treatments, and education and reassurance is very important to start with. Educating patients about what Tourette syndrome is, that it's a neurological condition, it's based on neurochemical imbalances, there's a genetic predisposition usually, and things like that, and also reassurances about the good outlook that many children either have a substantial improvement in their tics or even may have a resolution of tics after early teenage years. Those things go a long way in trying to reduce fear, anxiety, and guilt among the patient with Tourette syndrome as well as the family. And when those things improve, generally we do find that the level of stress goes way down. And we typically do find with education and reassurance that there's a period of time when the tics themselves will improve. Tics are quite sensitive to stress and emotional factors, and with education and reassurance alone, it can be a very powerful and improve the severity of tics. If needed, we refer people for information and referral to some of the agencies that are available, such as the NJCTS or the National Association for Tourette Syndrome and Associated Disorders. And as you know, they have very excellent educational materials, videos, and lots of programs that can be quite supportive and helpful. We do recommend support groups. Just interacting with other children or adults with Tourette syndrome can be very helpful. Patients find out they're not the only ones who are suffering from these problems of Tourette syndrome. There's often mutual exchanges of helpful information about how to cope with Tourette syndrome. Also, as you know, NJCTS can provide for school visits with adults can come in the classroom and educate children about what Tourette syndrome is, answer questions. And also, there are peers with Tourette syndrome who will volunteer and are trained to do the same sort of thing. I think these sorts of interventions are particularly important for young kids where teasing or bullying is something that's going on. One general principle that's important throughout the care of a child or individual with Tourette syndrome, I think, is to emphasize their self-confidence and their self-esteem. It's very important to provide very positive messages, even about how well they're coping with things. Because in my experience, if a child maintains good self-confidence and good self-esteem, they'll be able to cope well with whatever becomes them, whatever problems with tics or associated disorders, and generally will have a successful outcome. So it's important not just to focus on the tics themselves, but often also these emotional issues like self-confidence and self-esteem. The most commonly used formal non-pharmacologic treatment involves what's called habit reversal therapy, or HRT. And this is often bundled in other psychological treatments like cognitive behavioral therapy as part of what's called CBIT. That's a comprehensive behavioral intervention therapy that has had growing popularity in the US and around the world for treating Tourette syndrome and associated disorders. Basically, with habit reversal therapy, the therapist helps the individual with Tourette syndrome to recognize the presence of urges to tic and also what are called premonitory sensations. There are commonly sensations at the site of a tic for which the individual feels the discomfort and then performs the tic in order to lessen the discomfort. For example, with an eye blinking tic, individuals might feel a dryness or a discomfort in the eyes and feel that they have to do an eye blinking tic in order to relieve that discomfort. Oftentimes there is very temporary relief of the discomfort and it comes back and the whole cycle begins again with more eye blinking tics. But the therapist teaches the individual to recognize the urge and that premonitory sensation and to immediately try to replace the involuntary tic with a voluntary movement that's called a competing response. The competing response is generally something that's opposite to the tic itself and is also designed to be less noticeable to other people, so there's less embarrassment associated with the tic. So as an example for the eye blinking tic, the therapist may have the child develop a competing response that involves opening the eyes wide. And if they do the voluntary eye opening as soon as they feel the urge or the premonitory sensation and practice this, people can learn to replace the tic with the voluntary response many times. It is time consuming and it takes time, and it is largely reserved for people who have the noticeable urge and they can appreciate the premonitory sensations. I'm having trouble advancing.
You probably need to just click on your PowerPoint slide one more time and then try and find those buttons because there you go.
Oh, there we go. Okay, sorry about that. Now, to start off, I wanted to just give the audience some basic principles related to the pharmacology of Tourette syndrome. It looks like the main chemical dysfunction in Tourette's is the presence of what's called supersensitivity to the neurotransmitter chemical dopamine. Dopamine is a very commonly used chemical in the brain for nerve cells to communicate with each other. And based on scientific and experiential evidence, it looks like the part of the brain called the basal ganglia, the part of the brain which is very much involved in the control of movement, there's a supersensitivity and extra sensitivity to dopamine. And that's the main chemical dysfunction that we try to correct with the use of medications. And there are three main approaches to try to correct that deficit. The one is kind of an indirect effect, and that is by influencing a different neurochemical called norepinephrine. And when you change the level of norepinephrine with medications called alpha agonists, there seems to be an indirect improvement in that sensitivity to dopamine. So the alpha agonists is one of the most commonly used group of medications for Tourette's. Examples would include medications like guanfacine or Tenex and clonidine or Catapres or Capve, and we'll talk more about that in a minute. The second main medication treatment approach is to directly block the receptors for dopamine. These are on the membranes of the nerve cells that are receiving information. And if you block those receptors, the problem with supersensitivity seems to decrease. And this is the mechanism of another group of commonly used medications in Tourette's, the antipsychotics. Finally, another strategy is to inhibit the reuptake of dopamine. And what this refers to is when two nerve cells communicate with each other, they do so at a junction that's called a synapse. And the first nerve cell releases into that junction the neurochemical that will go across the junction and stimulate the next nerve cell. The nerve cell stimulates the receptors on the second nerve cell, and then the first nerve cell takes up the dopamine again to use it the next time the nerve cells want to communicate with each other. And it's been found if you inhibit that reuptake of the dopamine chemical, with medicines like tetrabenazine, that can lead to a decreased sensitivity to dopamine. It looks like by having extra dopamine in the junction, there's kind of a desensitization of the second cell, and that supersensitivity disappears. So I also wanted to just outline some general strategies about adjusting medications, because they pretty much apply to all the medications I'm going to talk about. The first principle is to start low and go slow. And what this means is it's generally best to start any medication at a very low dose and to try to gradually adjust or titrate the dosage upward, to not start with high doses and not adjust quickly. Usually the first type of medications when they're needed, that is when the non-pharmacologic treatments are inadequate, would be those alpha agonists. And the one that I tend to use, the one I like the best, is called guanfacine, or 10X is the brand name. The general goal of the medication is to keep the tics tolerable for the patient. I always tell people that we're not going to eliminate all the tics, but we want to adjust our treatments so the tics do not cause disabilities, they do not interfere with function, they don't cause psychological problems, they don't cause problems with self-confidence, self-esteem, or interfere with social interactions. So the goal is really to keep the tics tolerable, basically under control. We generally add a second-line medicine to the alpha agonist, and the second-line medicine would generally be a form of an antipsychotic drug if the tics are disabling despite the use of the guanfacine. If guanfacine was never helpful, instead of adding the second-line medicine, generally we just replace it. There's no reason to continue a medication that has not been shown to be effective. Finally, there's what we call a third line of medications, and these are used if the first two lines, the first and second line, are ineffective or intolerable. Kind of the speed of how you move from first line to second line to third line really depends on that goal of just trying to keep the tics tolerable. We're always looking for the least number of medications, the lowest doses of medications, but if the tics are really disabling, there's no reason not to move up from first, second, third line and to adjust the medicines if needed. Usually with the generally reasonable amount of medications that are available, we tend to, for almost all patients, find some medication or some combination of medications that will give an adequate response. So as I mentioned, generally the first line medications fall within that group called the alpha agonists. The one I tend to use is guanfacine with the brand name 10X. The positive things about this medication is you only need to use it once a day, and bedtime is the usual time of dosing, which makes it pretty easy, especially for children. It's a good first-line medication because it's not an antipsychotic. And the antipsychotics, the second-line drugs, generally are associated with more potential side effects. Also, antipsychotics kind of have a bad image. A lot of online discussions and communications between parents of patients with Tourette syndrome talk about bad things about antipsychotics. But as I'll talk about later, if antipsychotics are used properly, they're generally very effective and very well tolerated. One tip I have is I do recommend that people avoid the form of guanfacine in the medication Intuniv. This is a medicine that's been increasingly used recently. It was designed to be a long-acting form of the medication, and it's only given once a day. But as I said, guanfacine itself only needs to be given once a day. So there's no real advantage of Intuniv. Intuniv is more expensive. It also tends to cause more side effects than guanfacine. And it has a problem of bioavailability. And this means that from pill to pill, there's a variation in how well Intuniv is absorbed into the bloodstream and gets to the brain. So I have not had very good luck with Intuniv. There are rumors that it may be taken off the market, actually. But I have much more success with just simple guanfacine. The main side effects of guanfacine include tiredness, which is less of a problem when it's given at bedtime. It's a medicine that was originally designed to treat high blood pressure, so it can lower blood pressure in some people and cause dizziness. In young children, it may cause irritability, and some people develop headaches as a side effect of guanfacine. Now, the second main alpha agonist is clonidine. It comes as the brand names Catapres or Capve. And generally, these have fallen out of favor with more people using guanfacine. And the reasons are that they tend to have to be given multiple times a day, and they're much more sedating than guanfacine. But a little tip is that there is a skin patch form of clonidine called Catapres TTS. So for young children who have trouble swallowing pills, this is an option that can be considered. If the first line set of medications is not satisfactory or poorly tolerated, then generally we'll move on to the second line of medications. And these are the antipsychotics. The newer versions of the antipsychotics developed in the last 15 or so years are called the atypical antipsychotics, and they're generally preferred over the older so-called classical antipsychotics. The most commonly used to suppress tics are risperidone or Risperdal and aripiprazole or Abilify. There's recently a very large trial in Tourette syndrome, the largest trial of treatment ever performed with the medication Abilify, and it was quite successful. It was quite a good medication in suppressing tics. The main side effects of the atypicals are sedation, weight gain, and also gynecomastia, which is the development of breast tissue in males. And there's actually a large class action lawsuit against Risperdal because of this. It's extremely rare. The main side effect of concern has been the weight gain, which is not a healthy thing for children being treated. The weight gain is often associated with the development of diabetes, and long-term treatment with the atypical antipsychotics can be somewhat dangerous, mainly because of the weight gain and the diabetes. And the pendulum is kind of starting to swing back to the original classical antipsychotics. I'm actually using one called flufenazine or Prolixin a lot more than I used to. It seems like it's a very well-tolerated medicine. It's easy to take. You just take it at bedtime. And it's quite a potent drug, so you only have to use very small doses of it for suppressing tics. Sort of the classic and original medication used to treat tics was haloperidol or the brand name Haldol. This is the medication that put Tourette syndrome on the map as being a neurological or neurochemical abnormality, and really was the first hint that there was an underlying supersensitivity to dopamine in the brain of individuals with Tourette syndrome. And it's still a useful medication today. One thing that really led to kind of the bad reputation for antipsychotics has been some potentially dangerous side effects that almost always do not occur in individuals with Tourette syndrome who are treated with these drugs. They're more common in individuals with schizophrenia and other psychiatric disorders who are treated with them. But you almost never see them in patients with Tourette syndrome who are treated with antipsychotics. These include acute dystonia, which is a condition where when you first start the drug, there can be an involuntary twisting or tightening of muscles. It often involves the neck or the jaw, and you pretty much need to get to an emergency room and get some treatment for it. Almost never is this seen in Tourette syndrome, though. Probably the reason for the reputation of antipsychotics is the condition tardive dyskinesia, which means late involuntary movements. And this is something, there are only a handful of case reports in the entire world of individuals with Tourette syndrome who develop tardive dyskinesia. The reason is that this is a condition in which the chronic use of antipsychotics that block dopamine receptors end up causing a supersensitivity of the receptors. And this basically mimics what occurs in Tourette syndrome. And it looks like the receptors are already supersensitive in Tourette syndrome. So the medication, the antipsychotic, can't really make it any worse. And as I said, you almost never see tardive dyskinesia. Another issue that's responsible for negative views of antipsychotics is something that's commonly discussed on lay websites and chat rooms, and that is a comment that my child became a zombie when they were put on antipsychotics. These are symptoms like loss of emotionality, loss of motivation, tiredness, and so I call it zombieism. But this really shouldn't happen, and I almost never see it. Zombieism, I think, was something that occurred particularly many years ago when doctors didn't realize that these antipsychotics tend to work best at quite low doses. So zombieism really just reflects an inappropriately excessive dose of an antipsychotic medicine. If the first two lines are unsatisfactory, there are a few medications that have some anecdotal evidence or that have some very small research experience with them. The first one is topiramate, or Topamax is the brand name. It's an anti-epileptic and anti-seizure drug, and it does seem to help occasionally for people with Tourette syndrome. It's not a predictable drug in terms of reducing tics, but when nothing else seems to work or be tolerated, it's something that's worth trying. One reason I don't really like the drug too much, particularly in children, is that one of the side effects is to cause problems with language. People have trouble finding the right word, conversing, and that has led to the late audience often calling this drug Dopamax, because people who take it often sound like dopes when they're talking. So this is something clearly I try to avoid, and especially in children. Clonazepam, or Klonopin, is a member of the commonly used drug family called benzodiazepines. Medicines like Valium, Ativan, and sleeping medications are in this group. Generally, almost any involuntary movement will be reduced to some extent with these benzodiazepines. And I think they're kind of mild indirect effects that if you reduce anxiety or you sedate somebody a little bit, most involuntary movements, including tics, will be reduced a little bit. The medication does tend to cause tiredness and sometimes imbalance. And I think it's a medicine, again, that can be considered, particularly when individuals are extremely anxious, and this tends to exacerbate their tics, or sometimes just to take the edge off of tics if needed. Another medicine called tetrabenazine has been around for a long time. It's difficult to get. It has to come from a specialty pharmacy, and it is one of the drugs that interferes with the reuptake of dopamine. It's not very much used because it tends to cause tiredness. And I've used the drug since the 1980s, and almost every patient I've treated has become depressed, and we end up having to stop the medication. So it's not a commonly used medicine. But the next slide shows you some good news. Just in the last few years, there have been new chemical derivatives of tetrabenazine that have been developed. They're called VMAT inhibitors, and that stands for vesicular monoamine transport inhibitors. And all that means is they inhibit the reuptake of dopamine. And they're specific in that they work only on dopamine, and they don't work on norepinephrine and epinephrine, which the original tetrabenazine affects. So by being very specific just for dopamine, these medicines seem to be able to suppress tics and at the same time avoid the side effects of tiredness and depression. One of them is called valbenazine, and I've been involved in several of the studies with valbenazine. And there's another one called deuterated tetrabenazine. And clinical trials of both drugs have been completed and have been quite successful. And the timing of the talk today is interesting because I just got a call from the CEO of the company that makes valbenazine, who told me that the FDA approved their drug today. So it's a monumental day for the available of a new medication for Tourette syndrome. It will be marketed under the brand name of Ingrezza, which I have no idea where that name came from. It kind of sounds like an Italian wine to me. But I do think that the availability of valbenazine and eventually deuterated tetrabenazine really will be major advances in the treatment of Tourette syndrome. I think they will probably become the second line choices. That is, you try the guanfacine first. If that's not satisfactory, then the second line would be to try valbenazine. Kind of exactly where it fits in terms of the various lines of treatment will to some extent be determined by how expensive the drug is and how soon insurance companies will accept the medication. But I think today is a good day for Tourette syndrome because this is quite a good medication. I've had a lot of good personal experience with it. Now, moving away from traditional medications, another good option to consider in treating patients with bad tics is the injection of Botox. And Botox represents botulinum toxin. It's the same toxin that causes illness in botulism. Most people have heard about it, about the Hollywood stars who get Botox to eliminate their facial wrinkles. But it has been found over the years that Botox can be injected into muscles that are causing tics and be extremely effective in substantially reducing the tics or even eliminating them. It is something that should definitely be considered if there are just a few, 1, 2, or 3 quite disabling tics. It tends to work best for the types of tics that are called dystonic, meaning that they look somewhat like the movement disorder dystonia. These are tics that are slow, twisting, or muscle spasms. They're often quite painful. And the ones that are most commonly treated involve the neck, the shoulders, the eyelids, and the jaw. One very fascinating thing about the use of Botox is that it's extremely good in very quickly relieving the pain that's associated with these dystonic tics. So the twisting and tightening of shoulders and the neck and sometimes the jaw can really cause very bad pain for patients. And Botox can be an extremely effective and rapidly working treatment for individuals with those sorts of problems. It is a temporary treatment. It lasts about 3 to 6 months on average. So people who have a good experience will get their Botox usually 2 or 3 times a year. It is important to go to a Botox specialist, especially one who has experience treating tics. I generally recommend looking for a movement disorders neurologist. There are a lot of doctors who are out there recommending Botox, but you really need an experienced expert because it takes a lot of experience and art and knowledge and skill to know which muscles to inject and also how much Botox to inject into each muscle. This is something that is starting to be covered by insurance for the treatment of tics, especially if they are dystonic tics, and the diagnosis of dystonia is used. Dystonia is actually an FDA-approved indication for Botox, so most insurance companies will cover it, and many are now starting to cover dystonic tics. Now, kind of the final last resort treatment for very disabling tics would be what's called deep brain stimulation surgery. And this is a procedure where the neurosurgeon makes they drill small holes in the skull. They may do it only on one side, or it may be needed on both sides of the brain. And through that small hole, they insert electrodes. A computer is used and imaging is used to make sure those electrodes on a wire are put in a very specific place in the brain. They're generally in the basal ganglia, the deep part of the brain that's thought to be disturbed in Tourette syndrome. And it turns out that there have been more than 100 cases worldwide of the use of deep brain stimulation for Tourette syndrome. But I would say that it has lost some interest. The interest has declined because the results have been mixed. Some people have had superior results, others have not had very good results, and some have actually worsened. There's a debate about which is the best target for the stimulation, and also it's not a benign procedure. Just by putting the electrodes in the brain can cause bleeding, stroke, infection, and other problems. We have learned from initial use that it should not be used in individuals with Tourette syndrome who have self-injurious behavior. Some of those individuals were some of the first patients ever treated with deep brain stimulation, and often they picked at the wires that are under the skin, or they picked at the stimulator and sometimes pulled the wires out. Some even pulled the wires out from the brain. It caused infections in a number of these cases. And so we now know not to use deep brain stimulation in individuals who have self-injurious behavior. It turns out that it may be a better treatment for the obsessive compulsive disorder that commonly is associated with Tourette syndrome. It has become, OCD is now an FDA-approved indication for deep brain stimulation, and it can be a very effective treatment. Now, when caring for an individual with Tourette syndrome, it's extremely important to focus not just on the tics, but also what's called the comorbidities or associated disorders. For some individuals, the associated disorders can really be more disabling than the tics themselves and may be the main target for treatment. So the two that are on this slide, ADHD and OCD, obsessive compulsive disorder, and ADHD is attention deficit hyperactivity disorder, are very, very common and associated in association with Tourette syndrome. And the combination of Tourette's with ADHD and OCD is called the triad of Tourette syndrome, the three main features of Tourette syndrome. So in most individuals, if you look hard enough, most individuals with Tourette's, you're going to find some evidence of ADHD and or OCD. The same holds true if you look at individuals who come to the doctor for OCD. It's very likely that you'll find evidence of tics or ADHD. And these conditions just go hand in glove. And it's not surprising because they seem to be related to dysfunction in the same part of the brain, namely the basal ganglia. And the basal ganglia is the part of the brain that allows an individual to stop something. So in Tourette's, the failure of the basal ganglia leads to an inability to stop the involuntary movements of tics. In ADHD, there's an inability to filter out or stop distracting information or to stop hyperactive behavior. And in OCD, there's a problem in terms of stopping the repetitive thoughts or the repetitive compulsions. So it's not surprising that they all occur together. The treatment for ADHD in someone with Tourette syndrome is not a lot different than treating ADHD without tics. The accommodations in school are very important through what are called 504 plans or IEPs, individualized educational plans. There are behavior treatments that can help individuals with organizing their work, helping control their hyperactivity. And there are a variety of devices and gadgets that are now available on the web. And these are some simple things like little devices that children can hold in their hands, and they can manipulate them while they're in a classroom to help control their hyperactivity. There's a watch that exists that will vibrate the child's wrist every 20 minutes to basically remind them to pay attention. And these sound kind of silly, but most parents tell me that they've had very good luck with these devices, and teachers generally are quite impressed with some of these devices. So they're worth looking into if you haven't heard of them. They're not expensive and they're easy to get. When medications are needed for treating ADHD in patients with Tourette's, guanfacine is even more of a first-line drug because it can help both the tics and ADHD. So it's a drug that can kill two birds with one stone, and it is a very efficient treatment. We do often try to use a medication called atomoxetine or Strattera. This is a non-stimulant medication. It's more in the family of antidepressant medications. It inhibits the reuptake of the chemical norepinephrine. And this is a drug that can be quite effective for helping ADHD. It's usually not as potent, but it tends to have fewer side effects. I was involved with the first studies of Strattera in children with Tourette syndrome, and it did a good job, and what was found is there was no worsening of tics, and in fact tics tended to be a little better on Strattera. But if needed, it's perfectly fine to use stimulants in individuals with Tourette syndrome. Doctors and pharmacists are often told that individuals with tics should not be treated with a stimulant. But that's clearly mythical information and is not based on good data. There are many, many studies now that have shown that the stimulant methylphenidate can be extremely effective in individuals with tics and Tourette syndrome. Our Tourette syndrome study group did one of the first trials, and we found that methylphenidate also did not worsen tics. In some cases, there was a transient slight worsening of tics, but by 6 weeks into treatment, the tics were actually less than when we started methylphenidate. And so it's actually a shame that doctors are told not to use stimulants. I do it all the time. Most specialists in Tourette syndrome will use methylphenidate containing products without much concern about it. I have lots and lots of Tourette patients who do extremely well on methylphenidate, and it really can change the lives of these patients. So methylphenidate is the one that seems safest. There are a variety of different brand names such as Concerta, Metadate, Focalin. The other type of stimulant, which are called the amphetamine salts, are a little less well studied, and my sense is they do increase tics a little bit in some patients, but they also can be used in the vast majority of individuals with Tourette's. These would be medicines like Adderall or Vyvanse. And there's so many different kinds of stimulants nowadays that there almost is always a type that is useful for each patient. There's stimulants that are called immediate release. They last about 2 to 4 hours. Then there's the extended or long release forms that last usually 6 to 8 hours. There's a skin patch form that lasts about 10 hours. And there are liquid forms of stimulants like Quillavant, and that can be used for young children who cannot swallow pills. OCD, as I said, is extremely commonly associated with Tourette's, and it can be the most disabling part of the condition. The standard non-pharmacologic or starting treatment is what's called cognitive behavioral therapy, or CBT, and this is something that really needs to be performed by someone who is well trained at CBT. It's a very practical, non-Freudian type of treatment, and most children and adults who have CBT find it very helpful. It gives them tools or skills that they can use to help reduce their obsessions and their compulsions, and it's really a good place to start. If CBT is insufficient, medications that can be quite helpful for OCD include what are called the selective serotonin reuptake inhibitors, the medicines like Prozac, Paxil, Zoloft, Lexapro. These are medicines that probably a third of people in the audience are taking. There is some evidence that they're extremely commonly used medicines in the general public. They tend to be quite well tolerated, and they can be extremely effective for OCD. You generally do have to use doses that are a little bit higher than doses that are used to treat depression. If the SSRIs are unsatisfactory, the atypical antipsychotics can be added, and usually only very low doses are needed. And finally, as I mentioned, deep brain stimulation has become an option for individuals with very disabling OCD, but it is an FDA-approved procedure now, and it's being used more and more commonly. ADHD and OCD are clearly the most common comorbidities in association with Tourette syndrome. On this slide are listed a number of other comorbid conditions that seem to be more common than expected in individuals with Tourette syndrome. They include depression, bipolar disorder, other anxiety disorders, phobias, impulse control disorders and rage attacks, learning disabilities, and some others. And right now it's not really clear whether they're part of the underlying neurobiology of Tourette syndrome or whether they're present in increased frequency related to the difficulties in life in terms of coping and emotional problems that individuals get just trying to live with their Tourette syndrome. So I'll stop there. This slide just tells you a little bit about the Center for Neurological and Neurodevelopmental Health, or CNNH, where I work. I just started here in the last 4 months, and it's really a unique place that I really love because under one roof we provide multidisciplinary evaluation and care for a lot of childhood and adult neuropsychiatric disorders. We have neurologists, child neurologists, neuropsychologists. We do cognitive behavioral therapy, behavior therapy, and we have a creative arts program. And so it's kind of a one-stop shop for individuals with Tourette syndrome and some related disorders. And we also have a very active research program. So I'm glad that these sort of resources are available to people in the Jersey area. I personally work in our main office in Voorhees 3 days a week, and our northern office in Rutherford, which is right next door to MetLife Stadium, 2 days a week. But there's also the same resources are in the office in Wall Township and King of Prussia, and the contact information is there if anyone's interested. So I hope this was informative, and I'm happy to answer any questions after any comments that are made. Thank you.
Well, thank you. And we are ready to roll here with questions. So I'm going to start immediately with one that's an interesting question. And are you aware of any stem cell treatment for TS?
I am not aware of any studies of stem cell treatments in Tourette syndrome. It's pretty unlikely that they will be of benefit for Tourette syndrome in any near future. One of the requirements for stem cell therapies is you kind of have to know where to put them. They actually, if you inject them into the bloodstream, they don't really cross the blood-brain barrier. And so that's a big problem for trying to use stem cells for brain or neurological disorders. I would, at this point, stay as far away from anybody who recommends using stem cells for the treatment of Tourette syndrome. There are a number of practitioners, I've seen a number in the New York City, New Jersey area that do offer stem cell treatments for almost everybody, for any condition. They're often extremely expensive, usually in the tens or thousands of dollars per treatment. They're not covered by insurance. There's no evidence that stem cell treatment is worthwhile for anything other than a very few handful of medical conditions. So it's a nice idea, but it's not even close to ready for prime time for Tourette syndrome and probably most childhood neurodevelopmental disorders for a long time.
Wow, that was quite an answer. Thank you. So I have a question, and this may get into the weeds a little bit, so you tell me if you can't go here, okay? But I had a question from someone with a 10-year-old child who was diagnosed with TS at 5. And she's been on pretty much the range of medications that you've talked about in your presentation tonight. And she's currently taking risperidone. And the question has come up about the long-term use of risperidone, and that the mom is concerned of having read something, or I'm not sure where this information came from, that long-term use could be damaging to reproductive organs. Can you comment on that?
I'm not aware of that data. The main concern of the long-term use of the atypical antipsychotics like risperidone relates to the metabolic syndrome that I mentioned. And this is a tendency for weight gain, and that's associated with diabetes. And those are things that are, of course, risk factors for problems like heart disease, strokes, and other things. Mm-hmm. That has been the main concern of using the atypical antipsychotics long-term. I actually have not heard any real scientific information about the effects on reproductive organs.
Okay, thank you. I have a question, and the person who posed the question says that this is, is this too simplified, I guess is really what she's saying. Would you say that TS would be the opposite of Parkinson's, or again, is that just a too simplified way of saying what goes on in your brain?
Well, what I outlined, I tried to present in terms of some general principles. It may seem simplified, but when you think about all the various options that I talked about, it turns out when you use them in combination, which we often have to do, there's almost an unlimited number of combinations of treatments. And that's a lot of what the art of treating Tourette syndrome is kind of knowing how to use combinations and how to adjust each member of a combination. So it actually turns out to be fairly complex when you think about these options. And we have a new one thrown into the mix, which I think is an advance with the availability of the valbenazine medicine. And it'll just take some time to see how much that kind of changes the usual approach to using medications for Tourette syndrome. And I'm hoping it will be well tolerated and effective, so we'll see how things go. In terms of thinking of Tourette's as the opposite of Parkinson's, there's some general truth to that in the sense that Parkinson's disease is a condition where there's a reduced amount of dopamine in the basal ganglia of the brain. And that's because in Parkinson's disease, there's a degeneration of brain cells that make dopamine. So the overall chemical problem in Parkinson's disease is a decrease or an inadequate amount of dopamine. And it is kind of the opposite in Tourette syndrome, but not completely the opposite. So in Tourette syndrome, there's no evidence that there's too much dopamine, but the evidence is that the brain is too sensitive to the normal amount of dopamine that is present. So in principle, you're using kind of opposite approaches. In Parkinson's disease, you're trying to build up dopamine and the effect of dopamine, whereas in Tourette syndrome, you're kind of blocking the effect of dopamine. So it is reasonable to think of it as kind of opposites, and that can kind of steer you into thinking about the rationale for the different kinds of medicines that are used in Tourette's compared to Parkinson's disease.
To just add to that, though, is there any evidence of any kind of a connection between TS and Parkinson's?
No, there's no connection at all.
Okay.
Individuals with Tourette syndrome have no increased risk of developing Parkinson's disease. There's no evidence that there are more members of a family of someone with Tourette syndrome who have Parkinson's disease. They're very, very different conditions. As I mentioned, Parkinson's disease is a neurodegenerative condition. The cells that make dopamine die off later in life. Tourette syndrome is thought to be a neurodevelopmental problem where the development of brain cells and their connections is disturbed. So they're really quite different conditions. There's really no evidence there's any relationship between the two. Keep in mind, again, some of the principles. Deep brain stimulation is used for Parkinson's disease, and it's also being used for Tourette syndrome, but very different targets are used. I mentioned that the basal ganglia kind of serves as a brake to help us stop certain things. It's thought that in Parkinson's disease, the brake is being applied too hard. There's too much braking. So the parts of the brain that are stimulated are those parts that kind of relieve the brake, takes the foot off the brake. In Tourette syndrome, it's very much the opposite. The parts of the brain that are stimulated with deep brain stimulation help somebody apply the brakes even harder. So there are these relationships again, but people don't really have to worry if they have a child with Tourette syndrome that they're going to develop Parkinson's disease. There's really no evidence for that at all.
Okay, thank you. So this questionnaire is interested in your thoughts about the similarities in symptoms between a teen who has TS and OCD and a teen who might have ASD.
Yeah, that's a good question. In my work here at CNNH, I'm actually seeing a lot of individuals with autism spectrum disorder. And in my career, I've been very impressed with the close relationship between Tourette syndrome and OCD and autism spectrum disorder. There's a big overlap in symptoms. So OCD, ADHD features are very common in people with Tourette syndrome. They're very common in people with autism spectrum disorder. There are a number of clinical overlaps. The thing that's missing in Tourette syndrome are the kind of typical social problems that one sees in autism spectrum disorder and helps to define that condition. where individuals with autism spectrum have lots of problems interacting with other people, understanding emotions, lack of eye contact, just not even understanding social interactions very well. That's just something you don't see in Tourette syndrome. Lots of people with autism spectrum disorder have tics. Some people call that Tourette syndrome. Myself and most researchers in Tourette syndrome prefer to not use the term Tourette syndrome in that situation, but to call it what we call a secondary tic disorder, meaning that the tics are secondary to the underlying autism spectrum disorder. But I'll have to say the more and more I learn about autism spectrum disorder, the more impressed I am about similarities. There have already been a few genes that have been found to be abnormal in both Tourette syndrome and autism spectrum disorder. So I think they are very closely related conditions. It doesn't seem like they're intimately closely related, but there definitely are some similarities between the two.
Okay, thank you. So I have an adult who's asking about taking Prozac currently and Wellbutrin for treating anxiety and depression. However, it's affecting my TS and my OCD negatively. But I'm afraid to combine them with other classes of medication. Do you have any advice in this department?
Yeah, I tend to stay away from Wellbutrin, mainly because its mechanism of action is related to the reuptake of dopamine. And I think in people with Tourette syndrome, you just don't want to play with dopamine unless you know exactly what you're doing with it. So the dopamine drugs, dopamine affecting drugs that we know help tics, as I mentioned, are the indirect effects of the alpha agonists, the direct effects of the antipsychotics, or the direct effects of the dopamine reuptake inhibitors. Wellbutrin often has unpredictable effects on dopamine, so I try to not mess with dopamine in people who have dopamine-related disorders like Parkinson's disease or Tourette syndrome. So it's probably not a great choice to use in someone with Tourette syndrome. On the other hand, Prozac is a very well-tolerated, useful medicine to treat OCD or depression in individuals with Tourette syndrome. It's a bit of an energizing antidepressant medication, which is one of the reasons it's commonly used. It doesn't cause a lot of sedation, and it doesn't cause a lot of increased appetite and weight gain. But the more stimulating antidepressants sometimes can bring out tics a little bit. So that's just something to think about. But in that person's situation, I would first try to replace the Wellbutrin with medicine that's not influencing dopamine.
Okay, thank you. Here's a question that's probably in the news a lot these days. Is there any research on treating TS with marijuana?
The Tourette syndrome study group has been trying to do studies of cannabis and Tourette syndrome for about 25 years. And we keep running up against political roadblocks. And it's very, very hard to do in the United States. So there's almost no research about it in the U.S. On the other hand, there are a few countries that have done some cannabis research in Tourette's. There have been a few papers that have come out of Holland and also a few that have come out of Israel. And the results involved really a small numbers of patients who were studied. And they're somewhat inconsistent, but the main conclusion right now, and this is of course preliminary because we don't have a lot of information, is that there does not seem to be a specific tic suppressing effects of marijuana and cannabis. But on the other hand, the tics are sometimes lessened just because there is a reduction in anxiety and stress. And everyone knows that anxiety and stress, nervousness, can kind of bring out tics.
Mm-hmm.
So you kind of get an effect that you see with the tranquilizing medicine Klonopin or clonazepam, or some people say that alcohol relaxes them and reduces tics. Others find different relaxing activities like yoga, mindfulness, exercise, other things that kind of just relax people. They can be useful in reducing tics. So it's not surprising that you might find some reduction from anything that helps relax people, but it does not seem to have a potent or a very specific tic suppressing effects. But anecdotally, a lot of patients with Tourette syndrome do say they feel better when they use cannabis, and it's hard to argue with it, and you really need well-controlled studies. But at this point, the jury is still kind of out.
Mm-hmm. Okay. Have a question about orthodontic devices. Now, this person who posted the question didn't say how old, so I'm assuming it's for a kid if it's an orthodontic device. So have you had any experience or any comments you could make on issues around that?
Yeah, there is a company that is pushing these orthodontic devices on the Tourette syndrome community. They often have a table at the annual meeting of the National Association. These are basically devices similar to what dentists and orthodontists use to treat the condition bruxism, which is tightening of the jaw, or some people use it to treat TMJ problems, temporomandibular jaw joint. And the manufacturer seems to say that using this device, particularly at night, can reduce tics, but I think they're focusing mainly on tics around the mouth and jaw. I have, a number of my patients have used it or tried it. I haven't heard particularly good responses. You know, I wouldn't be surprised if someone in the audience has used it or their child, but it's certainly not any kind of breakthrough. And also, as far as I know, there is no really scientific study of the device, no use of randomization or controls or any of the scientific principles that we need to really assess how effective a device would be.
So this device then isn't about protecting your teeth from someone who has a teeth clacking tic or anything like that. It's not about that. It's something else then.
Yeah, I mean, that is something that is done. We have for years used devices like this for individuals who have teeth clacking tics or bruxism tics where they grind their teeth during the nighttime. And those orthodontic devices are very similar, and they're simply mechanical devices to protect the teeth from smashing into each other or grinding down. But the manufacturer of this particular device is suggesting that it has a greater effect in terms of reducing tics in general, not just to protect the teeth or to protect the jaw.
Okay, that's interesting. All right. Have a question about habit reversal. In habit reversal treatment, is it likely or possible that whatever the competing action is given to a child who is doing habit reversal could become a tic?
I've actually never seen that happen. It's probably a better question for somebody who does the habit reversal directly, a psychologist. I have had hundreds of patients with Tourette syndrome have CBT in habit reversal, and I've never had one of them come back and tell me that their competing response has become a tic. My reservation with habit reversal is that for many, many years I would tell my patients to not focus or pay attention on their tics because there's really no value in doing that. And habit reversal is really the opposite approach, where patients are trained to be exquisitely focused on their tics and especially the urges and the premonitory sensations. And I have concerns that when that goes on during the day for kids in school, that if they're devoting a lot of their mental energy to try to notice their urges and their premonitory sensations, that it's actually stealing some degree of attention, and it may compromise their ability to pay attention or to get information in the classroom. And every time I go to dinner and sit next to somebody who does HRT, we always have a good-natured argument about that. Most HRT therapists don't want to think about it, and they haven't wanted to look at it. I think it is something that might be useful for research. But that's actually my main reservation about HRT.
Okay. We've gone a little bit over. A lot of people are still hanging on. I think we'll go for at least one more question.
Sure.
So have a question. Let me go back to, I just get this whole thing. So this goes back to your answer about stem cell treatment. And the question is stem cell treatment the same as pulsed electromagnetic field therapy?
Oh, no, there's no relationship between the two. So what's called repetitive transcranial magnetic stimulation is something that's being looked at for Tourette syndrome, for depression, for other neuropsychiatric conditions. And basically what this is a device that creates a magnetic field, and it's passed over the skull of an individual, and it transmits magnetic energy through the skull and into the brain. And the earliest forms of these devices did not penetrate very deeply into the brain, but some of the newer devices are able to penetrate much more deeply. They also can be more accurately focused. And so some people are thinking that these may in fact replace someday the deep brain stimulation surgery, so that you don't actually have to go put an electrical wire directly into the brain, but you might be able to stimulate it externally through the skull. And so it's gaining a lot of interest in conditions like autism spectrum disorder, depression, a number of different conditions. And it's been studied a little bit in Tourette syndrome. There have been mostly mixed reviews. It doesn't seem to have a very powerful effect on tics. But as I said, the technology is changing. It's getting more powerful, more focused. And so someday it potentially could be an effective treatment. But it really has nothing to do with stem cells.
Okay, then I think, thank you very much. I think we're going to wrap it up here. We've gone quite a bit over now. I'm going to turn this back over to Kelly. Dr. Kurlan, thank you very much. Really a lot of great information. We appreciate your time. And
my pleasure, thank you.
Now. Oh, you're most welcome.
Thank you for joining us on our webinar for Tourette syndrome medication. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that are not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, Game-Based Cognitive Behavioral Therapy, will be presented by Dr. Justin Mizrael and is scheduled for May 17th, 2017. This ends tonight's webinar. Thank you, Dr. Kurlan, for your presentation, and thank you everyone for attending. Good night.